Good evening, everyone. Thank you for joining us for our COVID vaccine in kids ages 5 to 11 years old webinar. We are so glad that you guys could join us tonight. We're excited to share this information with you, and I'm going to hand it over to Dr. Carrie Firestein, CEO of Allied Physicians Group. Dr. Firestein, take it away.
Thank you, Ari. And thank you to everybody who worked so hard to get this ready for today. COVID has forever changed our lives. Like 9/11, we're going to remember how things were before and how things are after. Nobody has paid the price as much as our children, who have had changes in the way they go to school, in the way they see their friends, in the way they see their grandparents, and the way they interact and have extracurricular activities. This vaccine brings us that much closer to getting things back to as much of a normal as we will have, and we'll all have to figure out really, what that is going forward. But this is going to get us there. I'm Carrie Firestein, Chief Executive Officer of Allied Physicians Group, practicing pediatrician for 35 years, mother of 3, and grandmother of 1. My grandson is 19 months old, and he was born right at the beginning of COVID, and he knows nothing else. Our children who are in the 2nd grade have never had a normal school year. That's why this vaccine is so exciting. Allied has been preparing for this for quite some time, knowing that it was coming down the pike. So we've been preparing this presentation to help everybody understand what's involved and what you should be doing. We've prepared our drive-through clinics. So there are 2 drive-through clinics that Allied is running on November 13th at Coleman Day Camp and on November 14th at Crestwood Day Camp. Both of those dates still have availability, and Ari will put the link into the chat so everybody knows how they can sign up. Initially, we sent it only to Allied patients, but at this point, there are some spots available. So if people want to share the link with friends who are looking for a vaccine on those days, then you can do that. Please try not to post it publicly on major sites or just on your Facebook group, because we are concerned about anti-vax people trying to interfere with what we're doing. There are going to be people who don't want to vaccinate their children, and that is their choice. Today, we're here to give you as much information as you need, and then you ultimately get to make the choice and decide what you want to do for your children. So a little bit more about the drive-through, because I did have some questions about that. There will be physicians on site. You can have as many people come in your car as you are registered. You do need to have everybody registered. We will only be giving COVID vaccine. We won't be giving flu. It was just too complicated, and we didn't want to take a chance on making errors. If your child cannot appropriately be vaccinated, in a drive-through, you can get out to get the shot, but if you anticipate that your child is going to take a lot of time or need special attention, then go to your pediatric office. Most of the Allied offices are giving the vaccine. If your office is not giving the vaccine, Ari will put a phone number in that you can call, and we will get you hooked up with one of our offices that is giving the vaccine. We took all of your questions, and most of them are going to be answered in the presentation as they go, but feel free to put more questions into the chat. I will try and get to them and the other panelists as we go. If not, we may answer some of them live. Anything we can't get to that we feel wasn't answered, we can answer in the email. Everybody who signed up today, actually everybody who is here tonight and everybody who signed up, even if they're not able to be here tonight, will get a copy of the presentation and any supplementary material that comes up tonight that we decide to give you. It's now my great pleasure to introduce our wonderful panel. Actually, I'm going to let them introduce themselves. We'll work backwards and then end up with the first speaker. So Dr. Levine, you want to start?
Which one?
Dr. Eric Levine, yes.
Hi, I'm Dr. Eric Levine. I'm a practicing pediatrician in White Plains, New York for almost 30 years. I'm a member of the board at Allied and just very excited to be giving this vaccine to the 5 to 11-year-olds. And actually today at our office was our first vaccine clinic, and the excitement on the kids and the families was just great. So it was a very exciting day for me.
Yeah, we started yesterday at my office. We gave 50 shots in the afternoon, and there was just a lot of excitement, a little bit of crying, but certainly the kids who were old enough and even the younger ones were very proud to be there and excited to be there. Dr. Strauss.
Hi, everyone. Thanks for spending some of your precious time today to join us and learn about this vaccine. My name is Ralph Strauss. I've been a practicing allergist and immunologist for the past 30 plus years. I went to Mount Sinai School of Medicine. I trained at the Schneider Children's Hospital before it became Cullen's, and I did my pediatric residency and allergy immunology fellowship there. And again, excited to share with you my thoughts on this vaccine.
Now, Rachel Levine, are you officially a Dr. Levine now?
I am officially Dr. Levine.
Congratulations. I think
Thank
the last time we did our talk, you were still a PhD candidate.
Yes.
So why don't you tell us a little bit about yourself?
Hi, everyone. I am Dr. Rachel Levine. Unlike the other Dr. Levine, my doctorate is not in medicine. It's in molecular microbiology, and I'm a virologist by training. So I'm a scientist who studies viruses, and I have a special interest, and I currently work on respiratory viral infections like SARS-CoV-2, and that's where my interests lie. And I'm excited to share the science behind the vaccine tonight.
Great. Ari, you want to start the presentation?
All right, so let's jump right into the science behind the COVID-19 vaccine, how it works, and why we know it's safe and effective. Next slide. So what actually happens when we get infected with SARS-CoV-2, which is the virus that causes COVID-19? Next slide. Yeah. So let's think about what happens when we get infected, or when someone gets infected with SARS-CoV-2, which is the virus that causes COVID-19. So it comes in through the mouth and the nose, and then it starts to replicate or make copies of itself in our upper respiratory tract. And when the virus replicates or makes a large amount of copies of itself, that's what makes us sick. And that causes all the symptoms that we know and now can identify as COVID-19: cough, shortness of breath, fever, loss of taste and smell. And our immune system does go to work to fight this virus. It makes antibodies and other immune cells. But we tend to think of these as dirty. Some of these antibodies are good. Some of them are what's called neutralizing, where they will bind to the virus the next time it comes in to try and block it from getting into cells and replicating and cause disease. But some of them may not be as good. Some of them are not neutralizing. A lot of questions we still have about this natural immunity or immunity from infection is we don't know how durable it is. We don't know how long it's going to last. And it's pretty dirty. And in addition to that, the outcomes of infection with SARS-CoV-2 or COVID-19 are so diverse. Next slide. So that's one of the things that makes this virus very dangerous is we know some people are lucky and they are carriers, or they're just asymptomatically infected. They have it and they don't even know it. Some people get mildly ill, maybe it's no worse than a bad cold or a flu, but some people get really sick and they need to be hospitalized and they may need help breathing and need a ventilator. We don't really know. We know some risk factors, but we can't necessarily predict where someone is going to lie on that spectrum of disease. And in addition to that, we can all transmit it to others, and that could potentially be transmitting it to someone who does have risk factors for severe disease. The other thing we need to worry about with COVID is long COVID or post-acute COVID syndrome called PAX. And this, we've been hearing a lot about it on the news. So after people get over the acute phase of infection. So the first 10 days or so, they get better, but then they have these long-lasting debilitating symptoms like fatigue and brain fog, so they can't think clearly. And that's could be very detrimental in school. We know children can get long COVID, so they're not immune from that. The other thing we need to worry about with COVID in children is multi-system inflammatory syndrome in children, or MISC. We know, and we don't really know the risk factors. We can't necessarily predict which children will get MISC and which children won't. And this is a new virus, so there's a lot of unknown consequences of infection as well that we are just starting to learn about. One of them is myocarditis, and there could be a lot of other long-term consequences of infection that we don't know about. But what if I told you there was a way to get the antibodies and the immune cells to get them better than you would from being infected without any of the risks of infection? And that's through vaccination. Next slide. So there's a lot of different ways that we can make vaccines to mimic natural infection without any of the risks. So historically, what we've done is we've inactivated the virus with heat or high pressure. And that way the immune system sees the virus, they see the whole thing. But since the virus is dead, it can't replicate, so it can't cause disease. This is how we make the influenza vaccine, hepatitis A, and the Salk polio vaccine. But it does have some drawbacks, especially in a pandemic. It's really time consuming. Scientists like myself have to figure out how to grow the virus in the lab, which isn't necessarily so straightforward. And the manufacturing for that is pretty complex with living biological materials. So that's one way to make a vaccine. The other way to do it is to just give a part of the virus, or what's called a viral protein, usually the protein on the surface of the virus, so the part that the immune system is going to see first so it can make neutralizing antibodies. But since the virus is missing most of its parts, it can't cause any disease. So we have a bunch of these on the market: hepatitis B, Prevnar, which is the pneumonia vaccine, pertussis or whooping cough, and the meningitis ACWY. This method is time consuming, and it requires a lot of complex manufacturing because we're working with proteins, and our immune system is all about shape. And if the shape is even slightly wrong, the antibodies are not going to be good. So what if I told you that there was a way to get the shape right 100% of the time, because the shape is right 100% of the time when this is made inside humans. And that is just giving the instructions to the body to make that viral protein. So the immune system, or our cells, make that one protein, and the immune system sees it and recognizes it, makes antibodies. But since the instructions are only for one part, it can't cause disease. So this is Pfizer and Mrna COVID-19 vaccine. This is quick, it's very easy to change, and manufacturing is actually a lot simpler because there's no biological materials involved in any of the manufacturing. Next slide. So what are the instructions? So cellular messages are a little different than the messages you or I may use, a little different than texting. So cellular messages take the form of mRNA. And this is the central dogma of biology. It's been around for decades. If you have a high schooler in biology, this always shows up on the Regents exam. So DNA, which is in the nucleus of our cells, has all the instructions, and DNA has all the instructions for life. And then in order to make proteins, you have a message called messenger, or mRNA. And that messenger RNA goes out of the nucleus into the cytoplasm of the cell, which is outside the nucleus, and that makes a protein. And what's really important about this is that it cannot go backwards. So you can't go from protein to mRNA to DNA. You can only go forward. So importantly, this means that mRNA cannot change, modify, or in any way modify your DNA. You cannot go backwards. You can only go forwards. So let's recap mRNA vaccines. Next slide, and just go over a little bit more how they work. So the vaccine, which contains the mRNA, is injected into our arms, and it's actually, the RNA is enclosed in a fat bubble. It's like oil that you would have in your kitchen. And that's called a lipid nanoparticle, if you hear about it. And that helps the RNA just get into our cells easier. The mRNA is then translated by the ribosomes into proteins. And this is no different than any other mRNA that's in our cells, thousands of them making proteins for our hair, nails, and skin. The cell knows exactly what to do. The mRNA looks just like the mRNA that would code for normal proteins in our cells, hair, nails, skin, the enzymes that we need to digest our food. The mRNA goes nowhere near our DNA because it can't get into the nucleus or the control center of our cells. So once those spike proteins are made, they're put on the surface of the cell because that's what they're instructed to do. And our immune system says, hey, that's not hair, nails, or skin or enzymes that we need to digest our food. It thinks it's foreign or a virus, and it goes to work and it makes antibodies, or the foot soldiers of our immune system. Next slide. So those antibodies, they stick around for the next invasion to block the virus from replicating. So if the next time you see the virus is when you're exposed to it, you already have those antibodies there. They can bind the virus and neutralize it before it can ever get into your cells to replicate. And then the mRNA is destroyed like a Snapchat message. It does not stick around for long at all. mRNA is notoriously unstable. It maybe lasts a day or two. Next slide. So when these vaccines were introduced and widely available back in April, May of 2020, we saw a drastic reduction in cases of COVID-19 and deaths. So what we're looking at is the average daily cases per 100,000 people in the United States, separated out by those that are unvaccinated and those that are fully vaccinated. And we saw that while we clearly see that the death rates and the cases are higher in those that are unvaccinated versus those that are fully vaccinated, I just want to point out a couple of things. You see a smaller difference in the early summer months because there was less virus circulating, because we're able to bring it down with vaccination. And then, in the middle of July, almost August, the Delta variant took hold, which was much more transmissible. And you do start to see a little bit of an increase in fully vaccinated people, but that increase is not as nearly as high as it is in unvaccinated people. And they estimate that unvaccinated people have about 6 times a 6 times higher rate of cases than those that are fully vaccinated, and unvaccinated people are 12 times more likely to die from COVID than those fully vaccinated people. So these vaccines are working. This is exactly what we would expect from a highly effective vaccine. Next slide. So some quick facts. This technology for mRNA vaccines has been in the pipeline for decades. It was almost left off 20, 30 years ago as being too innovative. So this is not new. Scientists have been working on this for decades. About 6 billion vaccines have been given worldwide since December of 2020, when our first vaccines were available. And the side effects that we know are short-lived and they're not dangerous. They're a sign the immune system is doing its job, and I'll jump a little bit more into those in children in a little bit. And one thing that we know with vaccinology, which is the study of vaccines, is that historically any long-term effect from a vaccine will appear within about 6 to 8 weeks after it's administered. And in the United States, we have very, very robust mechanisms to collect data after people have been vaccinated. And we have not seen any concerning safety signals. So that is extremely reassuring. We haven't seen, there's no effect on fertility. Many women have gotten pregnant after being vaccinated and given birth to healthy babies that have antibodies. So they have some protection as well. Next slide. So one thing we know about the pediatric vaccine is that it's 1/3 the adult dose. Why is this? So the goal in all of these studies, in these clinical trials, was to find the lowest dose that elicits a protective response that's safe and tolerable. And that was the same goal from the adult trials. So you always want the lowest dose possible. So what they did is a phase 1 trial called dose escalation with immunobridging. So immunobridging is just a fancy word to measure levels of immune cells like antibodies that we think are correlates of protection and compare them to the 16 to 25-year-olds from the adult trial and see how similar or different. So they tested different doses and they looked at antibody levels, and they found that those children in the phase 1 trial that got 1/3 the dose had antibody levels similar to young adults, and it was safe and better tolerated than the 30 microgram adult dose. So they're getting the same antibody levels, but it's being tolerated much better. So that's why the pediatric dose is 1/3. It's to make it more tolerable without changing any efficacy. Next slide. So how do we know it works? We know it's safe from the phase 1 trials, but how do we know it works? So they enrolled about 2,300 children in the first group in gray here and randomized them 2-to-1. So about 1,500 children got the vaccine, and about 720 got placebo, which is salt water. And then these children were followed, just like I was when I was in the adult trial. And they measure antibody levels and they follow them for COVID-19 illness and, importantly, any safety signals. And then we started to see a little bit of myocarditis in older teenage males. So Pfizer enrolled another cohort of around 2,300 children. And so again, those children were randomized 2-to-1, and same thing, followed for antibodies, COVID-19 illness, and safety signals. Next slide. So when we look at the antibody levels, the antibodies that are neutralizing, the ones that bind the virus and prevent it from getting into cells, they saw that the antibodies were almost exactly the same as those from the 16 to 25-year-olds. So same level of antibodies, same amount, that's awesome. But we know that antibodies don't necessarily mean that it's working in the real world. So we want to look for evidence that it's also working in the real world. So is it, while the children have these antibodies, are they actually not getting COVID-19? Next slide. So that is exactly what we saw. We saw that those children in the vaccine group were not getting COVID at the same rate as those children that got the saltwater injection. So what we're looking at, when I'm showing you a graph, is on the horizontal axis, we're looking at days after the child got their first vaccine. And on the vertical axis, we're looking at the number of COVID positive children divided by the number of children that were in the placebo or the vaccine group. So while the number of cases in the placebo group, rapidly increased, the number in the vaccine group stayed the same. And that gave us about a 91% efficacy. So the placebo group accrued 16 cases, vaccine group accrued 3. While this seems like a small amount, mathematical modeling that's over my head shows that this is all you need to see efficacy. And what was really interesting, next slide, is that in the data set that Pfizer gave to the FDA, is that in the data set that Pfizer gave to the FDA, the COVID cases in the vaccine group were milder and the children had fewer symptoms. And that's exactly on par with what we were seeing in people 12 and older that were being vaccinated, is that the illness tended to be milder. So we know it's safe, we know it's effective, but what about those reactogenicity symptoms that some of us had after we got our vaccines, including myself? Next slide. So these are the side effects. We call them reactogenicity symptoms. We know that this dose was safe and well tolerated. There were no myocarditis events reported in any of the children in the trial, and there were no serious adverse events related to the vaccine that were reported. So if you read through the data set that Pfizer submitted, there were some events reported. In one instance, a child swallowed a penny another broke their arm. This has nothing to do with whether or not the child was being vaccinated. This is just a child being children. And then the reactogenicity symptoms that we all know is that the children from 5 to 11 actually had fewer frequency of these side effects than those in the 16 to 25-year-old group from the adult trial. So this 10 microgram dose is much better tolerated than the 30 microgram dose. And from this data, we would expect that children would have fewer of those side effects than the young adults. Next slide. So when we think about vaccination and its benefits on an individual level, the FDA did some modeling and they estimate that vaccination will prevent more than 40,000 cases of COVID-19 per 1 million vaccinated children. And this is very conservative estimates, so the benefits are likely to be greater. And importantly, the modeling predicts that more excess hospitalizations from COVID itself are prevented by the vaccine than the number of hospitalizations from myocarditis due to the vaccine. So we know that there is and this is also very conservative because one thing the FDA noted with the myocarditis was using a data set from Israel showing that the rates of myocarditis were a little bit higher in older teenage males, like the 16 and up, than the 12 to 15 that got vaccinated there. So they think that the rates of myocarditis will be even lower in the 5 to 11-year-olds because they're younger and because there's less RNA. And one thing I really, really want to highlight is that the risk of myocarditis is much higher from the virus itself than the vaccine. And importantly, any myocarditis case from the vaccine is extremely treatable. Physicians know exactly how to treat it. And most of them they resolve, whereas myocarditis from SARS-CoV-2 and from infection itself, it's up in the air. It's not being treated as successfully as it is from the vaccine. So in addition to all of this sophisticated modeling, we know that the vaccine is preventing the worst outcomes from COVID. It's likely preventing long COVID and MISC and other known and unknown complications of COVID itself. And it removes the need to quarantine after exposure per CDC guidelines, which is huge. And the general relief, I know I can speak personally, that I felt after I was vaccinated or found out that I was vaccinated in the trial. Next slide. And on a community level, the benefits are even greater. So if we can reduce the amount of virus in the community, we protect those that cannot get vaccinated, like children under 5, or those that aren't mounting effective responses to the vaccines, those that are immunocompromised. And as a virologist, I tend to think about this one a lot. Viruses can't mutate and create variants if they can't replicate. And if there's less variants being made, there's a reduced risk, a huge reduction in risk of a variant that escapes protection. Next slide. So we know that these vaccines will help prevent the emergence of new variants because each person that gets infected with COVID becomes essentially a viral factory. The virus is making millions of copies of itself. And each time it does this, it makes random mistakes or mutations. And some of those can change the shape of spike, which is the protein we are making antibodies to. And when it changes just enough to no longer fit perfectly into the antibodies from the vaccine, like a key into a lock, that's vaccine escape. Next slide. So vaccines help prevent infection and they reduce the viral load in infected individuals, limiting replication and the formation of new variants, which is so important. Next slide. So what about the possibility that there are escape variants? Well, that's the huge benefit of these mRNA vaccines. They're really quick and they're easy to change. So this technology allows faster changes than with inactivated viruses or protein subunit vaccines. And Pfizer and Moderna have already tested in early stage trials vaccines against specific variants like Delta, Alpha, which was the UK variant, Beta. So essentially all they do is they swap out the mRNA code to make the new spike. It's pretty simple and you can do it essentially overnight. Next slide. So some takeaway messages. This technology, although it's new, it's been rigorously studied for decades. These mRNA vaccines are safe and they're highly effective against symptomatic COVID-19 in children. And in science and medicine, we like to see things repeat. Moderna also had a press release from their children's trial that showed similar results for 5 to 11-year-olds. So this is adding more confidence to these vaccines being safe and effective. We know that high levels of vaccination here and around the world will prevent vaccine escape variants. And I think what's really important here is that COVID-19 is a dangerous virus with many unknowns, and the vaccine is preventing the worst. And that's it.
Thank you, Rachel. We're going to pass it over to Dr. Strauss.
Hi. So Dr. Levine did a great job explaining the science and data behind the unanimous approval of the vaccine for use in children. But there are many emotional and ethical considerations to work through as well. I've heard your questions. Why give my child the vaccine now? Why not wait for the passage of time and more experience? Can anyone promise me there won't be any long-term complications? Many of us can live with the risk of my child getting sick from an infection, but can't live with the thought of knowing that I may have caused him or her harm. Can you get the next slide? We have dealt with these issues as a society before, but never in this lifetime, during a global pandemic and during a time when we are being constantly bombarded by different types of media that magnifies the concerns and generates attention by appealing to fear. We need to cut through the noise and spend some time asking the right questions before we arrive at an answer we are comfortable with. So I asked, what if there was a worldwide epidemic of a viral disease that most children caught and recovered from? Occasionally it can be severe, resulting in hospitalization and death. Although death is rare, it still claims the lives of several hundred children a year. It is much more severe in adults and vulnerable populations. If there was a vaccine available, would you give this to your child? I posed this question as a philosophical one, but we know there's a worldwide pandemic and it's caused the deaths of many. The pandemic will fade, but the virus isn't going away. It's unlikely that your child will avoid exposure to this virus. Although you may not know any child that has been really sick or hospitalized with it, you know that it can occur. Let's go to the next slide. Our minds don't process statistics well. Numbers of deaths are personal tragedies with their tears dried off. Let's talk about a single case of a parent who lost a child. This writer starts out, Olivia, my eldest daughter, caught the disease when she was 7 years old. As the illness took its usual course, I can remember reading to her often in bed and not feeling particularly alarmed about it. Then one morning, when she was well on the road to recovery, I was sitting on her bed showing how to play with some toys. And when it came to her turn, I noticed that her fingers and her mind were not working together, and she couldn't do anything. Are you feeling all right? I asked her. I feel all sleepy, she said. In an hour, she was unconscious. In 12 hours, she was dead. This was not a case of coronavirus, although it could have been. Go to the next slide. This was a child who died of measles, and the person who wrote this was the famous author Roald Dahl. Olivia died in 1962, just before the introduction of the measles vaccine. Dahl dedicated 2 of his books to her memory and became a passionate vaccine advocate. Measles has several similarities to COVID. It wasn't a big deal for most kids. Virtually all children got it, and most did just fine with it. Although like COVID, some were quite miserable with it. The number of deaths it caused in children in the United States before vaccination was available was similar to what COVID has done in the past year. But we have decided that we don't accept death and illness in children if they can be prevented. Can I have the next slide? Now I want you to pay close attention to this part because I have a shocking piece of news for you. Doctors and policymakers don't always get things right. I don't need to tell you about drugs and procedures that have caused harm and have been abandoned. We've seen so many changes in our COVID policy that we got whiplash from watching the news. And groups in our society, particularly minorities, have not received equal treatment in our medical system. But when it comes to vaccines, it is not a leap of faith. They actually work, and dramatically. This slide shows the elimination of deaths from disease after the introduction of the measles vaccine. The same was true for polio, diphtheria, and all the other immunizations you and your child have received. You just saw similar slides for the reduction in hospitalization and deaths from COVID during Dr. Levine's presentation. It is an amazing track record of lives saved and quality of lives improved. Next slide. It is really important to remember that this pandemic has affected children badly in many ways. This artwork shows children's expressions in response to the pandemic. Many children have lost a parent, grandparent, or someone in their lives. Children have lost many days to illness, testing, worrying, and quarantining after exposure. Time lost from schools and activities have taken a huge toll, and the mental health impact has been profound. Next slide. We are living through a pivotal time in history. We experienced the rapid changes in the computer and internet revolution. The biotechnology revolution is going to give us tremendous opportunities to treat illnesses faster and better than before. As a quick recap, a small piece of the virus's genetic code is packaged in a fat globule and uses the cell's machinery to manufacture just a piece of the virus, the spike protein that attaches itself to the cell. That mRNA is quickly degraded, cannot enter the cell nucleus or change the cell's genetic code. The spike protein by itself cannot cause infection. This is an ingenious method. Let's go to the next one. Our immune system is really complicated, but its job is to defend the body against foreign invaders. It does this after natural infection, but it locks in on the offending target better after it gets a primer from the vaccine on who the enemy really is. It then gets an advanced training course on defeating the enemy with that second dose of vaccine. There are several parts of our immune system. Antibodies are produced by B cells. They recognize foreign invaders and neutralize them. But it's usually T cells that do the work of helping, killing, and eliminating the foreign invader. We can only measure antibodies easily, but there is so much more to the story. Antibodies are a useful marker of immune response, but it is a mistake to focus excessively on whether you or your child may have antibodies. Next slide. No treatment's perfect. There is no such thing in life as zero risk. You probably experienced fever, muscle aches, and fatigue yourself after receiving the COVID vaccine. Rare events occur. Allergic reactions are a risk with any vaccine. Anaphylaxis, that most severe allergic reaction, shows up as hives, abdominal pain, difficulty breathing. The risk is about 1 in 100,000 with the COVID vaccines. It is treatable, and people recover within hours. That's the reason you and your child are observed for 15 minutes after receiving the shot. There have been no reported deaths from vaccine-induced anaphylaxis out of the hundreds of millions of doses given. Myocarditis, that's an inflammation of the heart muscle. Symptoms are chest pain, fatigue, and shortness of breath. It occurs in teenage boys and young men after the second vaccine dose. It's usually treated at home with rest and ibuprofen, but can result in hospitalization. As Dr. Levine pointed out, the important fact to remember about this complication is that it is much more likely to occur with the virus than the vaccine, and it's going to be more severe with the actual infection. The long-term risks Dr. Levine did a really good job on, but what about the long-term risks of the vaccine? That question mark is becoming really small as literally hundreds of millions of people have had the vaccine over the past year. There has never been a non-live virus vaccine that has caused a problem beyond the first few weeks, and this is a non-live virus. I won't repeat any of the internet myths here, but remember this: whatever you can imagine as a possible long-term risk for this vaccine would also happen with the virus, but probably a whole lot worse. The question is not, should I give my child the vaccine or not, but rather what poses the greater risk, the vaccine or the virus? Let's go on to the next slide. We need to address one other question when deciding whether to give your child this vaccine now. If your child had the opportunity to save someone else's life with no known risk to themselves and a small amount of discomfort, would you want him or her to do it? Next slide. We have already answered that question as well. In the 1960s, when I was a child, rubella came out as a new vaccine. The rubella infection poses no risk of significant illness to children, but causes birth defects and miscarriages in pregnant women. I remember the advertisements. That campaign appealed to me. You were a hero for getting it, and I understood it. Next slide. This is a graphic image that shows what happens when the virus has less and less people to infect. The more people that get vaccinated, the less opportunity for a virus to infect others and mutate. We will still see sporadic cases, but with less impact. Next slide. So we've already established that giving the COVID vaccine lowers the risk to your child from getting sick. It lowers the risk of hospitalization and death probably a whole lot more. The studies in children don't have the power to detect rare adverse events, but even if you factored that in the calculations, the benefits to the individual child strongly favor getting this vaccine. But why factor in the benefits to others in our decision making? Who really cares about these other immunocompromised people? Aren't they going to die anyway? These are our neighbors on chemotherapy, people who've had organ transplants, or their classmates who were born with disabled immune systems that don't work properly and can't respond to the vaccine. Who are the patients at high risk for severe disease? These are our children's grandparents and family members with high blood pressure, diabetes, lung, kidney disease. Your child would not want anyone they love to become sick if they could stop it. Next slide. So are there any children who should not get the vaccine? One thing we have learned is that if you've already had COVID, you do not have permanent immunity. You are probably immune for the next 3 months, but plenty of people get hospitalized who previously had COVID and have high antibody titers for it. There is too much emphasis on antibody titers, in my opinion. It is a research tool that's good for studying populations, but it should not be used at this time to make a clinical decision for an individual. There are very few contraindications to getting this vaccine. If your child has allergies to foods, medications, the environment, they can get this vaccine. If your child has had a severe allergic reaction to another vaccine, talk to an allergist, but in almost all cases, it can be administered. Next slide. I framed this discussion by asking 2 questions. If there was a way to prevent this disease in my child, would I do it? If my child can save someone else's life with no increased risk to themselves, would I want them to? It is very clear that giving the COVID vaccine dramatically lowers your child's risk of getting sick. The peace of mind that you get for yourself and your family is considerable. The question you must decide is, what is the best option for my child now? Remember that no decision or putting it off is a decision. I have seen plenty of people who got very sick while they were waiting just a little longer to get the vaccine. Next slide. I just want to leave you with a final thought. I'm also a patient who's dealt with life-threatening illnesses for myself and my family. It's a very vulnerable and stressful position to be in. The good thing is I believe all of you have a vaccine expert whom you trust with your child's health. After today's webinar, please discuss any remaining concerns, not with your friends or your neighbors or that guy on Facebook you've been arguing with, but with your child's pediatrician or family doctor. If you tuned in today because you want my opinion, based on how this vaccine works and the very strong data that we've already accumulated from its use in hundreds of millions of people from around the world, I am certain your child is best off getting the COVID vaccine as soon as possible.
Thank you, Ralph and Rachel. So much of what I'm going to say has already been said by Dr. Strauss and the other Dr. Levine. Some of the conversations Rachel and I have had, you'll see that it's very similar. If you haven't figured it out, I'm Rachel's father, and she does a much better job than I do in presenting, so just bear with me. So I'm going to be talking about myths, falsehoods, and side effects of the vaccine. So next slide. Let's just start off with the myths. Myths are put out there by anti-vaxxers, people who are maybe just afraid of vaccines. Let's just say from everything that we know and everything you've heard from Rachel and Dr. Strauss, the COVID vaccine is a safe, effective vaccine and the best way to protect your child, yourselves, your community, and your families. Some of the myths have been mentioned before, but we're just going to go through them again. Just to start, so you know where we're coming from, that there have been 6.3 million cases of COVID in the pediatric population. And in the 5 to 11-year-olds, 1.9 million cases. And COVID is the 8th leading cause of death in children. So this is not just a little bit, it's a big issue. So one of the big ones was the rapid development of the vaccine. Rachel's already discussed this. Coronavirus research has been underway for decades. The best part of the state of emergency was the scientists began to share information and they were able to build on these decades of research. And just to reiterate, no steps were skipped, clinical trials were done, and to know that the clinical trials on children didn't start until it was approved for the adults. Rachel already discussed dose escalation and how the children's dosing had already gotten there. So here's one of the other myths about puberty, which really is probably one of the things that parents with kids in this age group are worried about. As Rachel has discussed, mRNA does not go to DNA. There's no way to affect a person's DNA. There's been no reports of any pubertal issues or kids going into puberty in the last 18 to 20 months. We've seen 12-year-olds, 13-year-olds who were pre-pubertal when they got their first vaccine go into puberty the normal way. You've heard a lot about infertility. There are so many falsehoods out there and myths. There are no reports of infertility, like as Rachel said. There's been many babies born through this pandemic, as pediatricians can tell you. And basically, there's no mechanism of action that has ever been described by an anti-vaxxer on how this infertility would work. There's a lot of other information I can give you, but it's probably not particular to the 5 to 11 age groups. So the other ones is, it's not on my slide, but menstruation. We've heard reports that women have had alterations in their menstrual cycles. Well, getting the vaccine can be a stressful situation, and we know that menstrual cycles can be affected by stress. There's lots of studies going on, but any woman who's reported changes in their menstrual cycle, almost always they've returned to their normal menstrual cycles. Long-term side effects. As you've heard Dr. Strauss and Dr. Levine talk about, that no vaccine has ever had any history of long-term side effects that were not seen in the first 8 weeks. There have been over 360 million doses of of the vaccine given just in the United States in the last 15 to 18 months. And Rachel, I think, has been about 14 or 15 months since her first vaccine. We haven't heard any reports. Can the vaccine give me COVID? No. As you've heard Rachel and Dr. Strauss discuss, it's not a live virus. It cannot give you COVID. The vaccine, is it made from controversial substances? Well, we've heard Rachel discuss that it's the mRNA, the fats, the salts, the sugars, and we see all of those other things in other vaccines, IV fluids, IV medication. There is also the discussion of, is the vaccine made with fetal tissue? Well, the Pfizer and the Mrna vaccines the mRNA vaccines are not made with any fetal tissues. The J&J vaccine is based on an adenovirus, and the vaccine development was developed on a historical immature embryonic cell line, but the vaccine itself doesn't contain any embryonic cells, and the J&J is not approved in this age group, so it's not of a concern today. All right, then there are my favorite myths, the ones that keep going around, that the vaccine is really being chipped, you're being tracked. I would love it if I could track my children, that you're being magnetized. The newest one, which I really love, is that it makes you bioluminescence. It causes you to glow by producing an enzyme called luciferase. Love it. Never seen it, but if I can glow, it will really help for camping and getting into the dark basement. Next slide. Next slide. Okay. Some of the falsehoods that the vaccine doesn't work. Well, as Rachel has already explained, it's 91% effective. Go back one. 91% effective against symptomatic disease in the 5 to 11-year-olds. Post-vaccination deaths in adults is 0.0021%. It is such a lifesaver. It's unbelievable. We also know that it can reduce transmission. It does not eliminate transmission. And the best news is that the studies on the 5 to 11-year-olds were done during Delta. And so we know it works really well, okay? Children don't get sick. Well, as I said before, 6.3 million pediatric cases with 1.9 million in the 5 to 11-year-olds. There've been 8,300 pediatric hospitalizations, and 1/3 of these kids needing ICUs. There are 5,300 cases of MIS-C with the average age of 9, so that's in this age group. There have been close to 800 pediatric deaths. Every pediatric death is a tragedy. Yes, it's a very small number, but it is a tragedy. And as I've said, it's the 8th leading cause of death in children. One of the other falsehoods is you don't need to wear a mask post-vaccination. Well, we still need to wear masks. CDC still recommends masks. Schools are still requiring masks. You have to wear masks. And remember that children model parent behavior. You should be wearing your mask, so your children will wear their masks. One of the other things is, what if your child already had COVID? Well, Dr. Strauss and Dr. Levine have already discussed this. You should still get the vaccine. It's better protection. It will boost your child's protection. That's the most important thing. Next slide. Side effects of the vaccine. Rachel, again, has done most of my job. And the side effects are similar to adults, but again, what we are seeing of reports that it is less so. Sore arm, achiness, low fever, and the reports are less in number, less in severity. Rachel's already discussed the adverse events, and she took my jokes about the swallowed penny and the broken arm. Of the over 360 million doses that have been given, there have been 7,000 reports to what we call VAERS, Vaccine Adverse Event Report System. That's 0.0019%. And these are just reports. Anybody can make a report. That doesn't mean they're actually related to the vaccine. They're all researched stringently. Okay. Here's the big one, myocarditis. So what is myocarditis? Myocarditis is an inflammation of the heart muscle, and it's usually caused by viruses such as adenovirus. And if, as pediatricians, we've always known about myocarditis, and it tends to happen every spring, or what cardiologists call myocarditis season. What are the typical symptoms of myocarditis? Well, that could include chest pain, fatigue, rapid heart rate, rapid breathing, achiness, decreased energy. Especially in the younger kids, they're not going to know what feeling your heart beat fast is. They're going to be sluggish. They're going to be tired. Can they run some low-grade fever? Yes. But you're going to know, as parents, we know our children, you're going to see that they're not themselves. But with the vaccine, we know that the greatest risk of the myocarditis is in the 15 to 30-year-old males after their second dose. And there have been about 900 cases per 100 million doses given, which is about 0.1%. And it's highest more in the 16 to 25-year-olds, and we're seeing less in the 12 to 15-year-olds. All the vaccine-related cases are what we call self-limited, meaning that they are treated at home and within a few months, weeks to months, it is completely resolved. But the interesting thing is, what about myocarditis in people who have had COVID? Well, there was one study done in NCAA athletes looking at myocarditis post-disease. And what they came up with, looking at symptoms and studies, that 2.3% of these athletes had myocarditis post illness. So if you look at it, the myocarditis from the vaccine is much less of a risk than actually getting it from the illness. Now, the 5 to 11-year-olds, the study has shown no myocarditis. And Rachel showed you the slides. There's been about 5,000 kids who have been followed, and we have not seen any. This is a very rare side effect by the numbers I've shown you. So we're going to need to look at it, but looking at the modeling, the numbers, if we see any, are going to be much lower. So that's great news, okay? Dr. Offit, who we consider the vaccine guru, which you may see all over the news, he feels that myocarditis is more of a pubertal or post-pubertal issue, so these prepubertal kids may have actually less myocarditis. Okay, next slide. So what are the numbers? I've given you the numbers. It's amazing the number of kids who have gotten COVID, and probably higher because parents don't want to get their kids swabbed. They don't want to hold them down. The kids don't like it. None of us like getting swabbed. So more than likely, the number of cases is higher than we know. There have been greater than 360 million doses. We've seen no long-term side effects. We've seen no increase in any diseases or autoimmune diseases. But there are reports of some diseases post-illness, which we are all following, and it's quite interesting. I can't wait to see more of the numbers, but it should make us want to give our kids the vaccine. So long haulers. We are seeing the long haulers in pediatrics. It is a post-COVID condition which lasts for weeks to months, with symptoms of fatigue, headache, trouble concentrating, muscle aches, joint pain, reduced physical activity. These kids have lost so much education already, and now that they're back in school, these long haulers can't concentrate. They have to stay out of school because they can't participate. We're seeing an increase in mental health issues, just not in we're seeing an increase in mental health issues in kids, but in these long haulers even more so. And it's not a small number. It's predicted, and looking at 7 to 8% of all pediatric cases will lead to long haul symptoms. All right, next slide, please. So what are my take home messages? Well, the benefits of the vaccine outweigh any risks, okay? 2 is, this is a question we get all the time as pediatrician, timing with other vaccines. Originally, when the vaccine came out, we were saying that there had to be a 2-week window between other vaccines. But what we've seen over time is we don't need that. You can actually what we call co-administer or get vaccines at the same time. You can get your flu vaccine at the same time, or any vaccine your child is actually ready for. If they're coming in for their well visit and your pediatrician is actually doing it at well visits. All right. So another question that we see is, my child is 11. Should I wait till 12 to get the higher dose? Well, the vaccine is not based on weight. Rachel is 100 pounds and her father weighs a lot more, and we got the same dose. So it's not based on weight. It's based on age. All vaccines have always been based on age. So that we saw from Rachel's data that the neutralizing titers were similar to the 16 to 25-year-olds. So as the CDC says, if your child is eligible, get the vaccine. So if your child is 11, take the pediatric doses. Here's the other question that we get a lot. So my child is 11, will get the first dose, but before they get the second dose, they're turning 12. What do we do? Well, the first dose should be the pediatric dose. The second dose can be the pediatric dose, or it can be the adult dose. It could be either dose. Either one is an acceptable vaccination schedule by the CDC. All right, so the other thing is holidays are coming. Thanksgiving is coming. These kids will be partially vaccinated. So what are we recommending? What is the CDC recommending? Well, if you're Thanksgiving and going to Thanksgiving and everybody there is fully vaccinated, that means 2 weeks after a second dose, enjoy. You can treat it as pre-pandemic. If there is 1 or 2 people who are unvaccinated or partially vaccinated, more than likely you're okay. But if you have multiple people or people who are possibly immunocompromised, then you may want to take a more layered approach. Vaccinate as many people as you can. You may want to consider rapid antigen testing the day before, the day of your gathering. And the home antigen testing is available. While it is not as accurate as a PCR, the CDC is recommending it is better to test than not to test, especially for unvaccinated or people who cannot be vaccinated. The next thing to do after all of that, of course, is masking. Better yet, if you can eat outside, anybody got those extra heaters around, even better. The other thing you can do is increase airflow. Open the windows, open the doors. Airflow movement is important, okay? The other thing is, if anybody in your family who was supposed to be at your gathering has any sort of illness, they should not go. Very important. My other thing is, if you're flying and fully vaccinated, flying in itself is very safe. Airplanes have great air exchange. Unvaccinated children is still fairly safe. Of course, masking is required. It's in the airports. If you're there, wear your mask, keep your unvaccinated children away from other people, away from crowded bagging areas. So my take-home message, vaccinate everybody you can as soon as you can. Thank you.
Okay, wow, we covered some amazing ground and gave a lot of good information. I'm looking through, I answered, or together, mostly me, we answered 38 questions during the presentation. So while I was doing that, I may have missed some of what you guys were saying. So if I ask you to repeat something you said, it's because either I didn't hear it or it's important enough to repeat again. A lot of the questions I left were questions for Rachel, for the non-physician Dr. Levine, because most of the clinical questions I could handle myself. So I'm going to start with you, Rachel.
Sounds good.
Okay. Did they test any other dose besides 10 micrograms? And can you explain why weight isn't a factor and a 5-year-old gets the same dose as an 11-year dose? And how did they come up with the age groups that they did?
So I can answer the first part of the question, but the dosage based on age, not weight, is probably better suited maybe for the other Dr. Levine. So they did test 10 micrograms, which is 1/3 the adult dose, 20 micrograms, 2/3, and the full adult dose. They did that in the phase 1 trial. And that's very similar to what they did with the adult trials back in March of 2020. They tested a bunch of different doses. And they saw that the 10 microgram dose, so 1/3 the adult dose, was better tolerated. So those children had fewer of those reactogenicity symptoms, of fewer incidents of fever, of fatigue, of headache, all of those symptoms that aren't dangerous, but are uncomfortable. And there was no change in the immune response. So if the immune response is the same, we go with the lowest possible dose.
So that makes sense. Like with any medication, you want to give the smallest amount that gets you an effect.
Yes.
I will actually ask the question to Dr. Strauss, who's actually an immunologist as well as an allergist. Ralph, why is it that weight doesn't matter, that a large, 11-year-old is getting a lower dose than a small 12-year-old?
Well, actually, it's really based on your immune response, and that's based on age. So younger people usually have a more robust immune response, but they're actually more likely to get more adverse effects from, for instance, a vaccination like this. So it's never 100% clean. But what they, as Rachel was saying, they did find that based on your age, you make a great immune response when you're young with a smaller amount of vaccine.
Great. And then somebody asked specifically, were they able to test the concept that you get your first dose at 11, that's lower, and then you turn to 12 and you get the second dose at that higher group? I would think not, right?
No, there was no studies.
So Ralph, do you have a thought on that?
I listened to an infectious disease webinar recently where they said that, it really doesn't matter all that much. You're going to make a good immune response. Technically, they suggested that if you turn 12, you get the 30 microgram dose. But nothing wrong with getting the 10 either, as the other Dr. Levine said.
Okay, great. And Eric, I'm just going to call you all by your first name because there are too many Dr. Levines on this call. Now I forgot what I was going to ask. Yeah, no idea. I'll just ask one of the questions here. A child with autism, are they any, or there was a bunch of other pre-existing conditions, autism, asthma, seizure medicines, are any of these kids at increased risk from the vaccine?
They're at no increased risk of the vaccine. They're at increased risk from the illness. An autistic kid won't wear a mask properly. A seizure kid, if they have fever or illness, are more likely to have breakthrough seizures. So it's the vaccine itself, very safe for all of these kids. I'm sure there are some diseases where they are at greater risk, but my first patient today, first patient in our first COVID clinic, was a bone marrow transplant patient and her brother. And it couldn't have been the best thing of my day.
Wow. I mean, what we do know is that pre-existing conditions do make COVID worse. And autism is one of the conditions where children got sicker from COVID. So all of those pre-existing conditions are much more serious with COVID, and actually the vaccine does not affect them. Correct, Rachel?
Yeah, I have seen no studies that change the efficacy in children with underlying conditions. In fact, children with underlying conditions were enrolled in the trials to make sure that the population in the trial represented the population in the community.
Okay, somebody just put up about their child's bone age. Don't worry about bone age. It really has nothing to do with your immunologic status. And, you know, clearly they couldn't test all of these different scenarios, but we know how the immune system works, how puberty works, how development in children works. This is what pediatricians do, and that should really have no effect on anything that's going on. I'll answer this one. Will there be a 15-minute monitoring period post-vaccination at the drive-through event? There will. The plan is that you get the shot and you drive forward and you stay in one place for 15 minutes, and there will be people around in case you need any help. But Ralph, can you talk about allergies, people who have allergies to peanuts and amoxicillin and, you know, get a rash when they get a flu vaccine? What does any of this have to do with COVID, and how should the parents proceed?
Well, you know, I mentioned an allergic reaction is a possible adverse event from any vaccine. It's really rare. From the COVID vaccine, it's estimated it's about 1 in 100,000, which makes the car ride to the vaccine event a riskier choice. Okay, so if you've experienced an anaphylactic reaction, you're ahead of the game. You have an epinephrine injector. That's the antidote for any allergic reaction. It works. And I'm fond of telling my patients, you know, an allergic reaction is a bad day. COVID is a bad week at best. So I have no concerns at all about allergies. There have been concerns about allergic reactions to the vaccine. If you've had an anaphylactic reaction to the first dose of the vaccine, then you should definitely talk to an allergist. There are ways to get through and get that second dose, or we may decide to just call it a day and stop at the one. For patients who've experienced anaphylaxis to polyethylene glycol, which is the ingredient in Miralax, really rare, talk to an allergist. But in general, you don't have to worry about allergies, just get the vaccine.
And Ralph, what is the risk of anaphylaxis from COVID vaccine?
Again, to repeat that, it's probably about 1 in 100,000. That's pretty darn rare.
Gotcha. Rachel, did children have worse reactions after the second dose, just like adults?
They actually did better than the young adults in the trial, less frequency of those side effects. So they're doing better, they're tolerating it even better than young adults.
But are they worse after the second dose than they are after the first dose?
Yes, in general, but compared to the adults, the frequency is lower. But yes, it is more likely that a child will experience side effects after the second dose.
Okay. And Rachel, do we expect that this is going to be a yearly vaccine?
That's the question of the year. We don't know. So the comparison we like to make is with influenza or flu. Flu and coronavirus are really different viruses. Their biology or virology of them is very different. They behave differently. They replicate themselves differently. And COVID, the coronavirus, doesn't change in the same ways that flu does. So we really don't know as of now.
Okay. Do you know if the study specifically looked at children of color?
I did not look specifically at the demographics, but they made a point when they were doing the enrollment for all of these trials, children and the adult trials included, to make sure that there were minority groups included. I think it percentages close to 40%, or I think that was the goal. If you give me like 2 minutes, I can come back to it and pull it up.
Well, why don't we do this? We'll include that answer in the email we send out tomorrow. How's that?
Sounds good. I can also put it in the chat.
Oh, that would be great. So I'm trying to check the chat and the questions and go through everything that was sent in. I think we've pretty much gotten to everything. Does anybody, oh, I know, this was another question. Some of the parents, because they took Moderna, they would rather their child get Moderna because it just feels better to them. Do you have any information on why Moderna is taking so long in kids, or when it might come, Rachel?
Moderna started children's trials later than Pfizer, so they're just a couple weeks behind. But they did have a press release a couple weeks ago that said their vaccine was safe and elicited neutralizing antibodies. So we would expect, hopefully, that their data will be released. Full set of data will be released in the next couple weeks.
Okay, but Dr. Levine, the other Dr. Levine, would you wait for a Moderna vaccine?
I would not wait. You take as when the vaccines first came out, we said, take whatever you can get. Right now, take the Pfizer. I come from a house, half of us are Moderna, half of us are Pfizer. Take what is available for your children right now, which is just Pfizer. Get the children vaccinated. When the availability of a choice does occur for your next child who ages up, then you can make a decision, but I would not wait.
Okay. And what about all the people that are, ready to get vaccinated, but their child has a little sniffle or woke up with a sore throat that morning? What are your thoughts on them getting vaccinated?
Unless your child has a fever or sick, a little sniffle, and that's with a 5-year-old, that's gonna be pretty much your whole winter. Get your child vaccinated. You know what? If you're concerned, have your child seen by your pediatrician, get a clearance, get the vaccine.
Yeah, generally, if you're not in quarantine, then you can be vaccinated. So you may have been exposed from a friend who saw a friend who went to a party. If you do not know that you're in quarantine, then you should get vaccinated. Dr. Levine, with myocarditis, if your child has a heart murmur or any kind of pre-existing issue, does that make them more at risk for myocarditis?
I don't know if the studies actually show us that. The myocarditis just looked at a percentage, but I don't think having a underlying heart issue puts you at any greater risk of the myocarditis. You are at a greater risk of having a worse course of COVID illness. So if your child has an underlying heart issue, it is even more of a quote unquote push to get your child vaccinated.
I would agree with that. And I know we've answered this question, but it keeps coming up. Dr. Strauss, are children really getting sick with this? Like, is it worth taking that risk? COVID seems to be decreasing. Everybody else is getting vaccinated, so the rates in New York are lower. Can I just sit back, give it a month and see how everybody else does?
This is a really interesting question because it all depends on your perspective. If you're out in your community and you hear about kids getting really mild illness, they're sick for a few days, they're home, they're better, that's one perspective on it. If you are a doctor working in a pediatric ICU and you're seeing kids who are really, really sick, some kids are on ventilators, some kids are, just horribly ill, that's another perspective. If you're a pediatrician or an allergist like I am, and you're taking care of kids, doing telemedicine visits, let's say, and talking to parents who are really scared, their kids are really miserable, they're home from school for a week, it's not a fun illness, any way you look at it. So yeah, kids are really getting sick, they're really getting very sick with it, and it all depends on the numbers. We have seen 750,000 deaths of people in the United States from coronavirus. Only a few hundred have been kids. But if you told me that a few busloads of kids went off a cliff, that's a tragedy. That's something I want to do something about. And that's exactly what we're talking about with coronavirus in children. This is not something we should accept as normal. We're just going to put up with it. We've got the ability to prevent it and make this go way, way down. So I would not hesitate to recommend that for all children as quickly as possible.
Great. So every pediatrician in Allied is open to your questions, to calling and making a telemedicine visit and having this discussion. The drive-through is this weekend. There are still spots available. The second dose appointment will be scheduled at the exact time that you get your first dose. It will be 3 weeks later at about the same time. They'll let you know. If for whatever reason you cannot make that second dose 3 weeks later, there is the availability to get it at one of the Allied offices, and we can make that happen for you. Don't hesitate getting the first dose. We will help you get the second dose. If for whatever reason you can't get the second dose that day, it's acceptable to get it, Rachel, up to 6 weeks later, right? As soon as possible, but up to 6 weeks. The other Dr. Levine's shaking his head. And I think that's it. Dr. Strauss, you kind of just gave your last statement. Rachel, do you want to give a last statement?
Get vaccinated. As a scientist, I still love watching the trucks of holding vaccine shipments leave the factories. It's still incredibly inspiring to me to see this as a testament to what science can achieve. And every day I'm so grateful that everyone can be that almost everyone now can be vaccinated. And I'm looking forward to the day when children under 5 can be vaccinated.
And those studies are going on right now, correct?
They're going on right now.
I know my cousin, who is a pediatric GI doctor, had her 6-year-old enrolled in the 5 to 11 study and now has her 3-year-old enrolled. And it's amazing when I talk to other pediatricians how many of them have their children enrolled in these studies or are, looking to get their children enrolled in these studies. And I know within my office and the doctors that I've spoken to, they have all scheduled or already gotten their 5 to 11-year-old the shots. So, we walk the walk and talk the talk, and we put our kids out there. So you have to know that it's something that we really believe in. Eric, last words.
Get vaccinated as soon as you can, wherever you can. Just get your children protected. You're going to protect your child. You're going to protect your community. You're going to protect the elderly grandparents. You're going to just protect the country. Just get your children vaccinated.
Excellent. So the vaccine website was posted. We will send out an email tomorrow that has all of this information, including the website and a phone number to call if you have any difficulties. If you are not an Allied patient, we can make space for you. And then, of course, we would love you to consider becoming an Allied patient because we do a great job. So anyway, thank you, all of the panelists. Thank you, everybody who stayed an hour and a half with us. We don't usually go this long, but it really was an important conversation. And thank you, Ari, and the rest of Allied and Adjuvant who made this possible. Good night, everyone.